till the last speaker in spite of the nice weather. The topic that I got was dialysis tomorrow. Where is the future taking us? You can look at this at many different ways. My way today will mostly be technical and medical. So you could look from the side of epidemiology, you could look from the side of socioeconomics, but this will be essentially how I dream or I think or I suppose dialysis will be in future. Of course, to know exactly what's going to happen, you need to be a kind of fortune teller, and unfortunately, I'm not a fortune teller. So if what I'm going to tell you today is not right in 5 or 10 years, and if I'm still alive, don't kill me, and don't say you said that in 2017, and now it's absolutely untrue. Now, this is what we are going to discuss. First, and the largest part, on an increase of extracorporeal removal, then a short section on how to improve hemodynamic stability, a short section but very important, I think. And then adding removal irrespective of extracorporeal system, that's then something that has not entirely to do with dialysis, but which could be supportive to dialysis, and on the other hand, also could help in the pre-dialysis population. That's about intestinal generation of uremic toxins and influencing residual kidney function. Most of the thoughts that I'm going to express today were written down in this review paper from American Journal of Kidney Diseases last year. So we start with extracorporeal removal, and the first question that I'm going to try to answer is whether we can do much on improving what we have already. And my message will be that we are not at the maximum, but almost at the maximum, that there are not so many possibilities to go higher and better as part of removal as we have today. And why is that? Well, that's explained in this figure. That's a bit complex, but I guide you through it. In panel A, we are expressing the relationship between renal blood flow or dialyzer blood flow and dialysate flow to clearance. Now, the straight line is showing what would happen if the relationship between blood flow and dialysate, or blood flow and dialysate flow would be straightforward. But that's of course not the case. If you look at blood flow, the curve is tending to level off, but we don't get this maximum just because of the fact that we cannot get higher with dialyzer blood flows, like something like 500 mils per minute. And on the other hand, on the side of dialysate, we are really already almost at the plateau at what we have today, 500 to 600 milliliters per minute. If we are increasing above that, not much is happening, only the fact that we are using more water, and that is both an economical and an ecological problem, or at least it will become one in the next few decades or centuries. As a matter of fact, one of the problems of the dialysis, to my opinion, is the huge quantity of water that is used, and somehow there should be a solution to this. The other problem is that if you are improving adequacy of removal, at the same time you are punished at the end of dialysis by a rebound phenomenon. And the better your dialysis is, the more is your rebound. Why is that? Well, it is because the uremic toxins are distributed to the volume, that extra plasmatic in the tissues where they are exerting toxicity, but dialysis we are performing it on the blood side. So we are cleaning the blood, but we don't clean the tissues. The tissues always are lagging behind, and that gives this kind of exponential curve. You go down very steeply at the beginning. That's just because you're taking out of the blood but not out of the tissue, and then suddenly or gradually, as the tissue catches up, the slope becomes more moderate. But at the end of dialysis, the more efficient you become, the higher the rebound phenomenon will be. So it's somewhat of what you are doing is taken away. The only way to be more efficient on the one hand and not be punished by the rebound phenomenon is by a prolonging dialysis session, which is shown in the last panel of this figure. If you stop at 4 hours, we get this rebound. If you go on, you remove still a little bit further, but you get a smaller rebound phenomenon just because of the fact that you take more time and that more of the solute in the meanwhile has shifted from the extraplasmatic to the intraplasmatic compartment. But the main point is that we are somehow at the maximum. There may be improvements still in geometry of dialysis and what so on, but it will give not much of an effect. So we must think about something else. And to my personal opinion, adsorption is probably the main thing that is going to come in future that could help us forward. Now, one thing we sometimes do not realize is that adsorption was there already 40, 50 years ago with the READY system. The READY system that, as a matter of fact, was a very clever way on trying to decrease the quantity of dialysate by putting a sorbent on the dialysate plus an urease module that served to break down the urea, of which in the meanwhile we know that it is a toxin. Before we didn't believe that. But the READY system disappeared because it was releasing too much sodium and because it released also aluminum. But I think that the principle is okay, and I suppose that in the coming years we will see this principle coming back, and this will be at least an adjuvant to the way we are performing dialysis nowadays. Now, we should realize that adsorption has been around already since many years in intensive care, where it is essentially used to take away cytokines in patients with sepsis to prevent complications like ARDS and diffuse intravascular coagulation. But to my knowledge, the only randomized controlled trial in the intensive care setting, which is an Italian study, did not show any difference, probably because in the case of taking away cytokines, you are tipping over a balance and you don't know. Some patients do need their cytokines, in some it is too much, and then you get these complications, and if you take them away, you take away both the protective and the deleterious effect. But that on the side, that's more or less with adsorption the only hard outcome study that I ever could find. Now, our colleagues in Louvain have been trying this fractionated plasma separation and adsorption for the removal of protein-bound uremic toxins. Now, this fractionated plasma separation and adsorption, as a matter of fact, it's artificial liver. It's the Prometheus system that they applied in hemodialysis patients, and they quite convincingly could demonstrate that the removal, in this case of paracrysyl sulfate, was markedly enhanced. The broken line here is a classical high-flux hemodialysis, and the other one is the removal of paracrysol with this Prometheus system, so it is clear that the removal of protein-bound molecule is almost double. And if this is, of course, an extremely expensive system and that we should not use it clinically because of the cost, at least it is a demonstration, a proof of concept that we could go higher and further with this adsorptive system. Only they had to stop the study after 4 patients because they got major coagulation disturbances, the vascular excess clotted, and they could not go on. Probably that tells us that this, at least this type of adsorption, was not only taking away uremic toxins, but also was taking away, for instance, an anticoagulant factor from the blood of the patients. And of course, if you do this in liver patients because they have this bleeding tendency, you don't have this problem. But in dialysis patients who are mostly pro-coagulatory, it's then that the problem occurs. But at least we know from that study that we could do better in removing uremic toxins by adsorption. Now, this Austrian group, no, Swiss group, has been trying something in the same range that's very clever to my opinion, but also very difficult. This is an in vitro study, so it is not in vivo, and it has, to my knowledge also not been pursued afterwards. But this is a sham situation, a sham setup of what dialysis in reality does. There is this container of blood. They're sending that blood through a system, and at the end they are sampling the blood again, which corresponds to what we would do in vivo by returning the blood to the patient. And then the system that they are using is a system whereby they are adding metal beads that have been seeded with sorbent, in this case sorbent for digoxin and for IL-1 beta, and they mix that with the bloodstream, after which they send the blood through a strong magnetic field so that the metal beads are taken out, and that you get only the detoxifying function, and that's quite spectacular. This decrease of digoxin after some time of doing the experiment, or of IL-1 beta. The only problem is that this is quite a complex system, and I'm also personally afraid if one of these metal beads is not taken up by the magnetic field and ends up in the patient, that you are creating an embolism. So I think it's very clever, but I don't know whether this will go on into clinical practice. What follows here is also adsorption, and that's more realistic, that's more feasible. It's a Dutch study. Again, it's in vitro, but here they were seeding, covering the classical high flux membrane with a sorbent for protein-bound molecules. So here you get this combination of diffusion and at the same time adsorption. The experiment is as follows. It's running over 4 hours, and there is a check at 1 hour, that's red, and one at 4 hours, that's blue. And here on the left is a kind of control experiment. That's the standard. That's why the value is set at 100. And that's a classical high flux hemodialysis, the same membrane that they seeded with sorbent but without the sorbent. On the other hand, you see here the effect of the mixture. If beads of sorbent are mixed with the blood, that's of course something that we cannot do in dialysis unless we would do or follow the Swiss system that I described before. And then in the middle is what is clinically realistic. That is the membrane seeded with sorbent. So if you mix the blood with the sorbent, after 4 hours almost everything is out. I think this is a study on indoxyl sulfate. But also the effect, if you're seeding the dialyzer with the sorbent, is quite impressive. At 1 hour you are already at -60%, and at 4 hours you are at more than -80%. That's far more than whatever you would hope to obtain with classical hemodialysis, where you end up at something of -35 to maximum -40%. So this is certainly an option that can be further pursued in future, and this group is further working on other variants or more efficient variants even than the one that was described here. I must tell you that there are a number of initiatives going on in the Netherlands. This is called the Dutch Neo-Kidney. That's an initiative from the Dutch Kidney Foundation. They are supporting all sorts of research that will bring novelty into dialysis, that should result essentially in getting a more compact system that is more flexible for the patient, that allows him to travel, and on the same time that's also cheaper and that is using less money. But in this context, a lot of experiments are going on, and they are going into many, many directions. The hope is that at the end of the day, we will end with a wearable artificial kidney. I don't know whether this will come true. At the beginning, that was really their intention, their focus point. Now they think at doing something more realistic and ending up with a compact system that then further on could evolve to a wearable artificial kidney. And also this experiment has been done in the same context. Of course, if you try to reduce the quantity of dialysis water, one of the problems will be that you don't get enough removal essentially of phosphate and potassium, and this is then a specific sorbent that is put on the dialysate to take away the phosphate and the potassium, so that your diffusion gradient always remains high. And that's an experiment done in goats, so that's an in vivo experiment. You see the result of 3 experiments, and as you can see, there is a progressive and steady accumulation on the sorbent system of both potassium and phosphate, and this could be very helpful in making more efficient a recirculated dialysate system if we are going to develop something into that direction. There are also several groups in the world that are working on bio-artificial kidney. The idea there is to seed a dialyzer with living tubular cells, so that the tubular cells help the function of the dialysis membrane. The tubular cells are containing a number of pumps, that's organic acid pumps and other pumps, and they are removing uremic toxins. In the case of the tubulus, from the blood side to the urine, in this case, from the blood side to the dialysate side. So that's a very clever idea, to my opinion. There has been essentially over the last 20 years a lot of work in the United States, mostly by David Humes in Ann Arbor, but to my knowledge they only went for one in vivo experiment, and that was not in humans, but that was in dogs with sepsis, and that gave somewhat contradictory results. The RAD over here, that's the bio-artificial kidney, that's classical continuous renal replacement therapy. This is the effect on recovery of renal function. So you see that here, this bio-artificial device is inferior to CRRT, although the difference is not significant. But if they look at survival of the dogs, they got just the inverse, and here the bio-artificial kidney system is doing better than CRRT. It has not been continued, or there is no follow-up of this experiment that already happened in 2008. On the other hand, I know that there are again groups in the Netherlands that are working on that. My personal reflection would be that the feasibility will be more difficult than for adsorption, and for the simple reason that if you want to distribute this system through all dialysis centers in the world, that's almost impossible. How are you going to keep these tubular cells alive? And another problem is, of course, that these tubular cells, how do they work? How efficient are they? They are alive, that's right, and they are doing something, but are they really equal to a tubular cell in our body? That's very difficult to know, or even we know that it's not the case, at least not for the time being. So there are still quite serious problems before this will become, if it ever will become, clinical practice. But at least we will learn a lot from the experiments that are going on. Other groups are trying to change the physical condition of dialysis and hope in this way to increase the removal of uremic toxins. And this German group, at the time they were in Berlin, but now they are in Aachen in Germany. They have been developing an interesting system. It's a sort of pre-dilution hemodiafiltration where they infuse hypertonic saline that then is removed in the dialyzer by diffusion into the dialysate, the sodium I mean. And the idea is that the hypertonic saline will release more protein-bound uremic toxins so that it becomes better available for diffusion. And that's indeed what they are showing here in this in vitro experiment. I ask you to look only at here. This is the protein binding of indoxyl sulfate under a normal saline condition, 95%, that's what we see in vivo. And then you see it going down to 73%. So that should, at least in theory, improve the removal rate. And later on, they went on with a clinical study that was published this year, a pilot study where they assessed what was happening to paracrysyl sulfate on the one hand, that's on the left, and to indoxyl sulfate. But the results were somewhat deceiving. There was a trend for an improvement for this new system. These are the red bars. So the blue bars are hemodialysis. The gray bars are classical hemodiafiltration, and the hypertonic hemodiafiltration are the red bars. So you see there is only one significant difference. There's no difference for paracrysyl sulfate. There's no difference for total indoxyl sulfate. The only difference is for free indoxyl sulfate. And as you can see here, the difference is not versus hemodiafiltration, which by itself has already an added effect to hemodialysis, but the difference is only to hemodialysis. My personal fear with this system is that we are going to add maybe tiny quantities of sodium to the bloodstream of the patient that we do not see in one acute experiment, because these are acute experiments. But if we are doing this on the long run, that gradually sodium will be accumulated in the patient, and that this will lead to volume overload and hypertension. But probably the system will be improved and they come up with something better. And then we have this other method that some people are testing, that's high-frequency electric field. So here the blood is sent through a high-frequency electric field in the hope, again, to break down the protein binding. And that's indeed what they are finding. The removal rate of this protein bound toxic, that's phenylacetic acid, is increased by some 60% by applying this high-frequency electric field. But here again, there are some caveats, and I'm, for instance, afraid that this electric field will destroy some of the structure of proteins and of the blood cells that are crossing it, and maybe for the safety aspect, this needs to get a more extended evaluation. Of course, that's all highly sophisticated mumbo-jumbo, technical stuff. What we can do right now is, to my opinion, only to play around with time frames of dialysis. And that's, of course, the simpler method, and also what is feasible for the time being. Now, this is a study from our group where we exactly are assessing the impact of time on the removal of phosphate and of beta-2 microglobulin. So this is either in the same patient dialysis of 4 hours, that's orange, or 6 hours, that's red, and 8 hours, that's blue. Now you must know that we changed in this experiment only time. All the rest remained the same. So the same surface area, the same patient, but also the same quantity of blood going through the dialyzer and the same quantity of dialysate. That means that if for 4 hours we were using a blood flow of 300 milliliters per minute, for 8 hours we were using 150, and for 6 hours we were using 225. And in spite of having everything the same apart from time, we got these huge increases of removal adequacy, more than 80% for beta-2 microglobulin at 8 hours, in spite of the fact that KT/V urea exactly remained the same. So what is happening is just simply that we leave more time for beta-2 microglobulin to shift out of the organ compartment into the extraplasmatic compartment, and that will allow it to be better removed. So time, dialysis time, to my opinion, remains a very important thing that is often neglected. The question could be, is the same demonstrated for protein-bound toxins? The answer is yes and no. The first study by Carlo Basile in Italy was mimicking exactly our protocol, so the same thing with decreased blood flows if dialysis was longer. They were confirming what we have been finding for phosphorus and beta-2 microglobulin, but if they went to protein-bound compounds, they found no significant difference. Although there was a trend, there was 13% for homocysteine, 16% for indoxyl sulfate. So we reasoned, if that is the case, maybe if we keep the blood flow at the same level, don't change it for 8 hours, but stay at 300 mils per minute, and we keep also the dialysate flow, we may do better. And that's a study that we undertook together with a Dutch group in Maastricht. And here you see a whole series of protein-bound uremic toxins going from the lowest protein binding, that's paracrysyl glucuronide, to the highest binding here for CMPF. And there are 4 regimes, all in the same patients again. Hemodialysis for 4 hours, hemodiafiltration for 4 hours, that's the blue. Hemodialysis is the brown or orange, then the yellow for hemodialysis 8 hours, and the pink for hemodiafiltration 8 hours. So first of all, it's clear that especially at 8 hours, hemodiafiltration is not much of an added value. There are some differences, but they are relatively small. The big difference, to my opinion, is for the 8-hour regime as compared to the 4-hour regime. So there is this kind of gradient, a stepwise upgrade if you're moving from hemodialysis 4 to hemodiafiltration 4 to hemodialysis 8 to hemodiafiltration 8. But it's obvious that if we are keeping the blood flow and the dialysate flow the same, we can do better for protein-bound molecules than if we are decreasing blood flow and dialysate flow. So, of course, one of the most practical problems is that it's difficult to do these long time schedules in the conventional hospital hemodialysis setting. You are restrained with all kinds of practical problems, shifts, etc. And therefore, to our opinion, there is really a place for home hemodialysis, much more than it is used for the time being in many countries around the world. But probably one of the solutions will be that we need more simple systems like the ones that I described before with adsorption, and that this will make dialysis at home more successful. Now comes a brief part on improving hemodynamic stability. This is not really looking into the future. These are things that are happening already. I make here some sidestep to this movie, Midnight in Paris. It's one of the later Woody Allen films, a very good one. It's about a guy who goes on a holiday, a writer, an American writer who goes on an holiday in Paris, and who during the night, around midnight, more or less is catapulted into the previous times, mostly in the period between the First and the Second World War, and then meets all sorts of interesting people. And in this scene, you see him sitting with the back to us, and he is in a bistro, and he's eating together with Luis Buñuel, Salvador Dali, and then the fourth one I think was Man Ray or so. And he explains to Buñuel the scenario of the movie El Ángel Exterminador, just simply because he had seen the movie. So that's what I'm doing now to you. I'm telling you something about the future, but as a matter of fact, it's not the future. In part, it is the present. And you have these biofeedback systems. I think, to my opinion, hypotension in dialysis is and remains a very important problem, and a problem that I will show you some data in a few slides that is really quite important and has a high impact on the outcome of our patients. And in this meta-analysis, they are showing that these biofeedback systems are positive for hypotensive episodes, with this criticism that there is risk of bias. Most meta-analysis are saying that, and of course that it's not on hard outcomes if you imply that a hypotensive episode during a dialysis is not a hard outcome. I would slightly disagree with it. It's uncomfortable for the patient, and in the next slide you will see that it really has an impact. It's a very interesting study. It's from Chris McIntyre when he still was in the UK. Now he's in Canada. And what they are doing, they are randomizing patients into cool dialysis and standard dialysis. And they are looking at the ischemia of the brain. And above you see the evolution of the control group. So this is the number of ischemic lesions. So after 1 year, you see clearly that the number of ischemic lesions has been increasing, whereas there is no significant change in the group that was put on cool dialysate. Now, I think that's very important because this ischemia, of course, it's leading to dementia. It's probably making that people are dying more early. So I think that this is convincing argument that we should try to avoid dialysis, hypotension as much as possible. And again, I must say that prolonging dialysis is another solution to this problem, the simple solution. The others also, but probably to get it better, we have to combine several things. And this is the same group in Maastricht. It's in part of the same protocol where they also were looking at hypotensive episodes, and that where you see that there might be a slight advantage for hemodiafiltration over hemodialysis in both conditions. But again, the big gain is seen when we are doing this 8 hours hemodialysis and even slightly more for hemodiafiltration. So my conclusive slide of this part is the same one as of the previous part, that there should be more attention, at least to my opinion and the opinion of our group, to home hemodialysis. And now we are going back to the future, so two things that still have to happen. And what we are doing now is look at outside of the extracorporeal system, how are we going to help the extracorporeal system, and probably also how are we going to help the patient before he comes to dialysis. So we will look at the intestine, and we will look at prevention of progression of kidney disease. Two aspects will not be discussed, that's lifestyle and exercise on dialysis, but all the rest will briefly be discussed. So that's adding removal or decreasing concentration, at least irrespective of the extracorporeal system. And in this way, first of all, influencing intestinal generation. Now, the role of the intestine in uremia has been forgotten for many years. They were working on the intestine in the sepsis setting, in diabetes setting, in aging, but the kidney, the attention was drawn to it only about 7 years ago by this paper, and at the same time, the same year, also a paper from the group in Louvain that pointed out that the gut was a major origin for uremic toxins. Now, how does this work? Well, it's the similar mechanism as I explained yesterday for TMAO. You're starting from a precursor. In this case, for the cresols, it's an amino acid, it's tyrosine, so the product of intestinal digestion. And it comes into the intestine, and in the intestine it is transformed by the microbiota into a P cresol, which is an extremely toxic compound. We have for some time thought that P cresol was present in our dialysis patients, but that was a mistake. That was an error of the methodology when handling these samples. But in the intestine, this P cresol is there, and then when it crosses the intestinal wall, it is further conjugated to paracrysyl sulfate and detoxified. Detoxified, although paracrysyl sulfate is still a toxic compound, and from there it moves through the portal vein, crosses the liver, and from the liver it goes into the body. Some of the P cresol escapes and comes as such in the liver. It is transformed again into paracrysyl sulfate, and also in another conjugate that is paracrysyl glucuronide. And so we get these uremic toxins, not only protein bound, also some of them are not protein bound. Now, of course, the question is this real? Is there proof of concept that the intestine indeed plays a major role? And there are at least 4 excellent studies that are proving this. I'm going to show only this one by Aronoff and co-workers. What they are doing is a metabolomic analysis where they compare 2 situations, and they look for discriminators. So that's molecules of which the concentration is different in A and B. And A, in this case, is the regular hemodialysis patient with a colon, and B is hemodialysis patients without a colon. They looked throughout the United States, and they found 6 people who were dialyzed and who had no colon for various reasons, colitis or a tumor. And then they were checking with metabolomics where were the differences. So this is a huge list. I'm not going to detail with you, just to show you how many discriminators they found. And that's one table. There are 3 such tables in that paper. And in one of these columns, they are calculating the ratio between those with a colon and without a colon, which I do not look into detail either. What I look into detail is to the upper part, because here you have paracrysyl sulfate and indoxyl sulfate, And you see that the ratio is 0.01 for paracrysyl sulfate. That means that there is 100 times more paracrysyl sulfate in the plasma of a patient with a colon as of a patient without a colon. And for indoxyl sulfate, it's almost the same. The ratio is 0.02, so there's 50 times more in those with a colon as those without a colon. But that's not limited to indoxyl sulfate and paracrysyl sulfate. As you see, there is this whole column, and on top of that, there are 3 tables like that. So that means that we have a plethora of compounds, and it would be even remarkable if none of these would additionally exert toxicity. To a certain extent, our knowledge in that way is still remaining insufficient. But there is something else that is even more cumbersome. That is the fact that the uremic patient also produces more of these molecules than a healthy person. And the primary paper in that is by Nostratola Vaziri. It's in KI a few years ago. Technically, it could be done better. But on the other hand, it was an eye-opener, and I think a very important paper. Now, it's also a complex slide, but I will guide you through it. On the right are control subjects, and on the left, patients with chronic renal failure. And then they are measuring the quantity of intestinal microbiota. And this is shown in a color scale. The high concentration is white, and then they go through yellow, orange to red, and dark red is a low concentration. And now here in blue, you have the good bacteria. And that is those that are not producing uremic toxins or even are refraining the production of uremic toxins. And here in green, you have the bad guys, the ones that are producing uremic toxins. So it is clear that in a control condition, there is a lot of good bacteria, and that the quantity of bad bacteria is extremely low. But this relationship is completely inverted in uremia, where you see that there are very few good bacteria and a lot of bad bacteria. And that's, of course, very interesting. So here we are creating some sort of vicious circle. On the one hand, they do not go out through the kidneys, but on the other hand, the intestine is producing more of them. So that is the reason why for protein-bound molecules we get this exponential rise in concentration as compared, for instance, to a compound like urea or creatinine. And the question is, of course, what are the good guys? Well, you have these lactobacilli, also bifidobacterium, so that's everything that's in yogurt, activated yogurt, Activia. So that's the rationale for part of the therapeutic options that are considered for the time being and tested, but still with more or less debatable results. So what can we do about this? Of course, we can administer protein poor diet, but that's a risk for malnutrition unless we are adding keto analogs. Then you have this option of prebiotics, probiotics, and symbiotics. Prebiotics are compounds, non-digestible compounds that are modifying the intestinal microbiota, for instance, fiber, or for instance, inulin. And then you have probiotics that are living bacteria, living germs, like bifidobacterium, like lactobacillus, who are tipping the balance over in favor of bacteria, or at least germs that are producing less uremic toxins. And you have the symbiotics, that's a combination of pre and probiotics. And then you have sorbents, that's a totally different class. That's also an option that you give some compound that catches away uremic toxins from the intestine, uremic toxins or their precursors. Now, there is a huge amount of papers on prebiotics, probiotics, symbiotics, with very contradictory results, some doing something, some not, always only studying concentration, no hard outcomes, also contradictory sometimes in what they find for paracrysyl sulfate and indoxyl sulfate or other compounds, but that's maybe not so abnormal because probably these two molecules are metabolized or produced in a different way. This is certainly the most recent and the best study. It's a randomized control trial with a symbiotic. And as you can see, there is borderline significant advantage for the symbiotic for paracrysyl sulfate, but not for indoxyl sulfate. Now, the problem with this study, an unavoidable problem, was that of the 31 patients included in a follow-up of 6 months on hemodialysis, 10 or so of them had to receive antibiotics. And if you take the antibiotic preparation, take those who did not receive antibiotics, there is an error in the legend, excuse me for that. If you look at those receiving no antibiotics, then you can see that for paracrysyl sulfate, the difference is even more important, and that it also becomes significant for indoxyl sulfate. But that's, again, only on concentration, it's not on hard outcomes. To my personal opinion, our knowledge about the action of the intestinal microbiota and uremic toxins is insufficient. And these studies are going on by several groups, and probably that will help us to solve the problem of treatment more efficiently. The last option is influencing residual renal function, as already said yesterday also by Dr. Kalantar Zadeh, yesterday or the day before yesterday, I don't know exactly anymore. There is this quite steep relationship between uremic toxin concentration, between uremic toxin concentration and residual renal function. Here we're going from the right to the left, from 6 mils per minute GFR to 0. And especially for hippuric acid and paracrysyl sulfate, you see an increase of concentration by at least a factor of 3 when you go from the start of dialysis with 6 milliliters per minute to anuria. So that's much more important than the effect of any dialysis treatment. So preserving residual renal function is really an essential task in uremia and has not been enough attention paid to. Now, there was great hope with the sorbent AST120. That's a Japanese product that in this way progression of chronic kidney disease could be refrained. AST120 is a carbonaceous sorbent, only available in Asia, not in the Americas or in Europe. The rationale is that it catches away indoxyl sulfate, and indoxyl sulfate gives renal fibrosis, thus progression of kidney disease. And in this Japanese study, and there are 3 studies like that, there was really hope-giving. The decline of eGFR with AST120 was significantly less than in the control. Of note, this is secondary analysis, it's not primary analysis. But when this study was repeated in the United States, and in Europe, then no difference at all was found. In a study that could be criticized, there was no checkup or decent checkup, at least, of patient compliance, and there was also no checkup of what the concentration of indoxyl sulfate did. But some years later, there was this paper in CJASN that was done in Taiwan, and they found exactly the same. The only criticism here is now they started from very low indoxyl sulfate concentrations in both groups, so maybe they had no time to exert activity. But I think this is a dead end for the time being. On top of that, you have to realize that the patient then has to swallow several grams of carbonaceous stuff that may work in the beginning and that may work in an Asian, but it doesn't work in Europe and it doesn't work in the United States. So probably something better, a better sorbent, intestinal sorbent should be found, and then the work may go on. The other option is, of course, to influence inflammation. Inflammation is also destroying the kidneys. Here we end up with NF-kappa-B, and from NF-kappa-B we go to cytokines like MCP1. You have to remember that bardoxolone was inhibiting NF-kappa-B. That bardoxolone was out of the market afterwards, but it had a positive effect on the renal function. So I think that this idea still needs to be pursued. The study that I want to show you is on MCP1. That is also named CCR2 inhibitor. It's a randomized controlled trial It's only studying albuminuria, and this is the percentage change, so this is quite going up and down. The gray is the control experiment, the blue is the drug at the lowest doses, and the red at the highest doses. So there is a lot of bumping and jumping. There you could, with the lowest dose, say that there is some positive effect, but it remains a surrogate outcome. With the red, you see that there is very few difference, and that's also curious that more drug has less effect than less drug. So I think that this is not convincing enough, but there must be ways in the future to influence progression of kidney disease already before dialysis, but maybe also during dialysis. And of course, we have now a number of trials that came out in diabetes with sodium glucose cotransporter inhibition, empagliflozin, etc., that show positive results. And don't forget, although I think the large studies need to be done still, that also metformin has an antifibrotic effect, and not only in diabetics, also outside diabetes. So this could be also an option for the future. So in conclusion, there are several pathways are currently explored to increase solute removal by hemodialysis. There's adsorption, there is a modification of physical conditions, changes of the dialysis time frame. Several other pathways help preserving intradialytic hemodynamic stability and preventing ischemic damage. That's cooling dialysate, biofeedback systems, changes in dialysis time frame. Non-dialysis pathways explored for enhancing removal are influencing intestinal generation and influencing residual kidney function. I thank you for your attention.